बस से भी है
उधर कहाँ तू जा
यहीं से तो ब्लूटूथ ऑन होता है ब्लूटूथ पे
Can
क्लिक
you
करके
mute it,
पॉड्स
Rajesh?
निकाले
Sir, 1 second, sir.
You can mute everybody.
पॉड्स निकाल के रखे अभी नहीं अभी जब लू आएगा ना
We can
तब
move everybody.
अभी रुक जाओ अभी कनेक्ट
Push the button. Okay, see it. See
You can
it.
start, sir.
Yeah.
Start. Video start.
Very good evening. Today we are observing National Epilepsy Day. Before the going details, I invite the IAP President Dr. Radhi Shantakumar to give her welcome address. Over to Dr. Radhi Shantakumar.
Good evening, everybody. Today we observe the National Epilepsy Day, which has been celebrated by the National Epilepsy Foundation. The main aim here is what we do is with small actions, we are trying to make big changes, either by the talks that like what we are holding here now, or having small talks and awareness for the public, teaching them certain things like first aid for seizures, the 3 words, stay safe and sight, and what they mean, so that with these kind of actions, we can save many lives. And with doing some more programs like having funds for research and other activities, all our voices together can be heard and make a big change in the community. So I begin with my welcome, and the first person I have to welcome is our IAP State President, Dr. Narayanan, for the presidential address. A warm welcome to you, sir. This program cannot be complete without our inaugural address by Dr. Anandakeshwan, who's the past president of IAP Neurology Chapter and the National South Zone Vice President. Sir really worked to make this day happen, and we appreciate, sir, for the hard work from your side. For felicitation, we have both our State Secretary, Dr. Balachandar, and our Thrissur District Secretary, Dr. Srijit, and Dr. Mukesh, our State Vice President-elect. A warm welcome to you all. Dr. Rajesh, we are very happy that you are here today for the function and will deliver the vote of thanks. The inaugural function will be later on started, followed by the scientific session, where we have the topic for the day, practical management of pediatric epilepsy. And it will be delivered by Professor Dr. Madhusudanan, who is the professor and head Department of Neurology, retired from the Government Medical College, Kottayam. I do remember the so many innumerable night duties I have done, and where with the advent of new drugs, when a child comes with status, should I use levetiracetam first, or should I use should I use phenytoin first? Should I treat every twitch? Well, today after this talk, I suppose I will not have to think too much. We'll be listening very eagerly for your talk, sir. I hand over the next session to Dr. Narayanan for the presidential address.
Unmute.
Good evening to you all. Dr. Radhi Shantakumar, President of IAP Thrissur branch, Dr. Anandakeshwan, IAP South Zone National President, Professor Madhusudan sir, Dr. Srijit, and my dear friends in IAP Thrissur and IAP Kerala, respected seniors. First of all, congratulations to IAP Thrissur branch for organizing this awareness program on the National Epilepsy Day. We all know that epilepsy is a very common clinical entity in neurology outpatient departments, and not an uncommon presentation in the general pediatrics OP. actually determining the precise etiology of epilepsy is really challenging. Of course, neuroimaging and video EEG has made a lot of changes in this field, but the non-availability of genetic testing and the investigations for inborn errors of metabolism in most of the areas in our state still makes it very difficult. So a number of epilepsies are still classified as idiopathic. And of course, childhood epilepsies differ from adult epilepsy because of the wide spectrum of the presentation, mainly due to the immaturity of the newborn and infantile neuronal connections, and also the lower seizure threshold to fever or to temperature fluctuations in children, which causes febrile seizures, and CNS infections, trauma, tumors, all those things which are seen in children. So, and in the treatment part, of course, the newer anti-epileptic drugs have made the prognosis better, but still a small percentage of epilepsies remain refractory to treatment. Then regarding the awareness on epilepsy, on which we are for this day is devoted, we all know, I think most of the people, at least doctors know, there have been a lot of famous people in the history who had epilepsy. The list is very long, like Agatha Christie, Alexander the Great, Alfred Nobel, Aristotle, Charles Dickens, Julius Caesar, Leonardo da Vinci, Martin Luther King, Napoleon Bonaparte, Peter the Great, Socrates, Sir Isaac Newton, then Theodore Roosevelt. All these people, these great people had epilepsy. Still, even now, even after centuries, the stigma, the misunderstanding of our epilepsy is still continuing. It is expected in a country where even in today's news, we heard that somebody has killed a little girl to take her liver and eat as a cure for infertility. It has happened in UP. So that's a kind of things happening in North India, even in South India. You have seen in that movie where Manoj Jain, Sargam movie, where Manoj Jain is holding a bunch of keys to stop the epileptic seizure he was suffering. So those things are there. Still, it is our duty to see that, to spread the message that epilepsy is a treatable condition, and if properly treated, they can lead a normal life. That message we should be able to spread to the public, and even during these COVID times, we will be able to do that through our social media, which is the IAP social media is very active, our Facebook, YouTube, and all. So I request all the members to utilize our social media for the awareness program on epilepsy and other diseases. So I wish this program all success, and I again congratulate the Thrissur team for organizing this session. Thank you.
Nidhi,
I invite Dr. Anandakeshwan sir for the inaugural address.
very good evening. Respected Chairperson Dr. Narayanan, President of IAP Thrissur, Dr. Reddy, Secretary Dr. Srijit, State Secretary Dr. Bala, today's chief guest, our own respected Madhu sir, Head of the Department of Pediatrics, Medical College, Thrissur, Dr. Purushothaman, Medical College, Jubilee Medical College, Dr. Vinod Japitherian, Dr. Professor Chitralega from IAP, then Dr. V.K. Parvati Madam from Amala Institute and Medical College, retired professor from Manila, and many other senior members and APLs from all over India. It's also I would like to congratulate IAP Thrissur and IAP Pediatric Neurology Chapter for organizing this CME in connection with the National Epilepsy Day. I think the last so many years IAP Thrissur is organizing CME in association with the National Epilepsy Day. Epilepsy is already discussed is something different in pediatric age group from adult. It's a very heavy burden for developing countries, especially India, and about 1/6 of the epilepsies from India in all over the world. At present in my ward, 50% of patients are occupied by epilepsy related problem, and the 2 patients children are on ACTH. That much of significant it is there. Some of them are West syndrome, neurodegenerative disorder, febrile seizure, development delay, cerebral palsy related problems. So many things are there, totally different from pediatric area. And the sad aspects of this one is a refractory epilepsy. We had 1, 2, 3, then 4 drugs, even though there won't be much benefit from all this. Ketogenic diet, somehow it is well described, but it is not easily available and also very costly also. Another aspect is that, as Narayana rightly mentioned, stigmata of epilepsy, still it is there. And many drugs, even though government medical college, they are providing some drugs, not always. Sometimes they will get it, sometimes they won't get it. Again, lead to regular treatment. All epilepsy drugs are very, very costly also, especially the newer one. There are so many areas in pediatric epilepsy also, whether what about in newer drugs, use of newer drugs in children, first line, first line, some confusion. First seizure, whether you are treated or not. So much investigation. Previously, we used to do some EEG alone. Nowadays, I think almost all cases of epilepsy, we forced to do MRI. So there are so many changes are taking place. Today, we are lucky to have a eminent speaker, teacher, academician, and a great person to me, Professor Madhusudan sir, to discuss all these aspects. So I think the CME will be great benefit for all the pediatrics. That is why we selected such a simple topic, because the simple practical management of epilepsy for pediatricians. Today there are 5, 6 concurrent CMEs going on in Kerala itself. Then also we can see a very good number, around 100 people are there, and plus in YouTube also people are watching it. So I think that is the importance of this topic. I wish the CME and the scientific program all the best. Once again, I welcome on personal behalf Professor Madhusudan sir and wish the program all success. Over to Didi. Unmute.
Thank you, sir. Next, we have felicitation. I invite Dr. Mukesh, State Vice President-elect, for the address, to address us. Dr. Mukesh. Dr. Mukesh.
Unmute.
I am unmuted.
Mukesh.
Respected President, Dr. Reddy, State President, Dr. Narayan, and National Vice President, Dr. Anandakesavan, and dignitaries on and off the dais, I wish this CME and the scientific program all the success on this auspicious day of National Epilepsy Day. Thank you, sir.
Thank you, Dr. Mukesh. Next, I invite Dr. Balachandar, State's IAP Secretary, to address us. Dr. Balachandar.
Unmute, Mahendra.
Dr. Balachandar.
Unmute Bhalandran. Unmute. Oh,
Thank you.
okay.
Thank you, ma'am. Actually, I cannot unmute. Actually, the host has to unmute me. And that's what.
Okay.
Respected President IAP Thrissur, Riddhi ma'am, Jayesh sir, respected teacher Madhusudan sir, Dr. Rajesh, Purushothaman sir, Srijit, and all my seniors and friends. First of all, let me congratulate IAP Thrissur for not for observing the National Epilepsy Day, but for bringing an excellent speaker in Madhusudan sir, an excellent teacher, and also an excellent topic which we come across in our day-to-day practice. Madhusudan sir, I know because I am in Kottayam for the last 20 years, even though I studied in Trivandrum. He took Rajesh sir at Trivandrum to me. And I am lucky to have him for the Neurocon in 2015 at Kottayam. So I'm not taking much time. I'm already late. So I wish this program all the success and congratulate once again IAP. Thank you. Jai Hind, Jai IAP.
Thank you, Dr. Balachandar. I invite Dr. Rajesh for the vote of thanks.
Rajesh is State Secretary of IAP Neurology
State
Chapter.
Yeah.
And he is from BMH Kozhikode.
Hello, good evening, everybody. First of all, let me thank Dr. Riddhi Madam, Dr. Srijit, Anandakeshwan sir for organizing this meeting and taking the lead in it. I thank them for this great evening, bringing this great lecture from Madhusudanan sir. I thank Dr. Narayanan sir for the inaugural address, presidential address, and Dr. Anandakeshwan sir for the inaugural address and bringing out all the relevant aspects of why we are observing the National Epilepsy Day to increase the awareness among public and doctors, and very relevant points. Then I thank Dr. Mukesh and Dr. Balachandar for being here and for the felicitations. Also thank Dr. Madhusudan sir for taking his time to be here and to share his wide experience on a very important and practically relevant talk to the pediatricians. And also thank all the senior faculty, senior members who are in the audience, and all the participants who have taken time to be with us this evening. And once again, thank you all for the great evening, and look forward to hearing a great talk from Madhusudan sir. Thank you.
Thank you, Dr. Rajesh. So the inaugural program has come to an end and we begin the scientific session shortly. I welcome Professor Madhusudan sir, Professor and Head Department of Neurology, retired from the Government Medical College, Kottayam. So we eagerly await to hear your topic on the practical management of pediatric epilepsy.
I invited Dr. Srijit to introduce our speaker, our Secretary IAP Thrissur. Over to Srijit.
Okay, thank you, sir, for calling me to invite. Actually, Madhusudan sir requires no introduction to this ground, but this is a job given to me, so I will give a few words. And Dr. Madhusudan sir is now the professor and HOD of neurology at Kemco Medicity, Kollam, and he also is the adjunct professor at the Manipal University. And as Madam said, he is a former HOD of neurology at Medical College, Kottayam. And Madhusudan sir had more than 4 decades of teaching experience in neurology, and he had publications in both national and international journals, and he had authored many chapters in leading textbooks of neurology, and he had many orations to his name, and he has given numerous guest lectures, and is an examiner for DM neurology to prestigious institutes of India like Srijitra, and he is also a well organizer and has organized numerous conferences, and he has done numerous public awareness programs. And so with this vast experience, we are waiting for his talk, sir. Over to Mazmoon, sir. Thank you, sir.
Thank you, Srijit. First of all, a very good evening to all of you, to my dear colleagues and friends, and the nice words spoken about me. When Ananda Keshavan invited me to give this talk and asked me to talk on pediatric epilepsy treatment, I told him that I am not a pediatric neurologist, I am an adult neurologist. But he insisted. And so what I've decided is that I'll talk about the basic principles of management of epilepsy, which is applicable to both children as well as in adults. And if time permits, I will talk about the various childhood epileptic syndromes and the management. But I will not be touching upon the neonatal epilepsy because the management of neonatal stage is entirely a different ball game. Their investigations and treatment is all different. So with these few words of introduction, I will share my screen. Are you able to see my screen now?
Yes, coming.
Yeah.
So two things are there. Now the number exceeds 100. So those who can watch in YouTube also the program, it is more than 100 now. Second thing is that you can type your questions here. Please type your questions, sir. Sorry, sir. Thank you, sir.
Yeah. So if you look at the magnitude of the problem, as you know, the epilepsy affects approximately 1 in 50 children and 1 in 100 adults. The treatment for epilepsy is largely individualized, more so in children. And AD therapy leads to seizure freedom in about 70% of all children with epilepsy. Now, coming to the principle of therapy is basically the same as in adults, except for certain things. The choice of drug should not cause any cognitive and behavioral side effects in children. The drug treatment is different in certain unique age-dependent syndromes which are solely seen in children. The dosage adjustments vary depending upon the age of the child and associate comorbid conditions like inborn errors of metabolism or mitochondrial disease, where some drugs are contraindicated. So with that introduction, I will come to the various issues which we face in the pharmacotherapy of epilepsy. First of all, is treatment justified? Do we want to start treatment in each and every patient, every child with epilepsy? How to start the drug treatment? Which anti-epileptic drug will you use? What if the first anti-epileptic drug fails to control the seizure? And what dosage and how long should treatment be continued? These are the aspects I'll be dealing with. Come to the first aspect, is the treatment justified? There are certain situations where anti-epileptic drug treatment is usually not justified. First is uncertainty about the nature of the seizures. Second is febrile seizures. Single unprovoked tonic-clonic seizure. Seizures precipitated by avoidable triggers. Certain benign epileptic syndromes like benign rolantic epilepsy, benign occipital epilepsy, and long interval between the seizures. I will not be dealing with all these factors one by one, only mention about certain factors. One is uncertainty about the nature of the seizures. Because very many conditions in children can mimic seizures, as you all know. I did not talk to you about these various conditions like convulsive syncope, breath-holding spells, paroxysmal dystonia, nocturnal myoclonus, shuddering effects, etc., etc. So this has to be excluded before you brand the child as having a seizure. Now, what about a child coming with a single unprovoked seizure? Now, the diagnosis of epilepsy is made when the child has 2 or more unprovoked seizures, or if the predicted risk of recurrence of seizure is 60% or more after the first episode. You can also start provided the risk of that particular seizure is more than 60% even after the first episode. However, generally, anti-epileptic drugs are started after 2 unprovoked attacks or when the predicted risk is more than 60%. Now, what is the risk of recurrence after the first attack? It is after the first attack, generally 42% in 2 years with overall incidence. After the second seizure, it is 79 to 96%. That means it goes without saying that after second seizure, the child needs treatment. Now, in the case of first episode, what are the factors linked to the increased recurrence of the first seizure mandating treatment? The 2 important factors an abnormal EEG, and seizures related to a remote brain insult. But remember that there are no definite association with the neonatal seizures, febrile seizures, positive family history, and age and sex of the patient. So what are the practical suggestions in a child with first episode of unprovoked seizure? AEDs are generally not started. It is started even after the first attack in certain situations where there is a high chance of recurrence. For example, first episode with tuberous sclerosis, you find muscle malformation of the cortical development, acute encephalitis, abnormal EEG, history of previous infiltrate to the brain like cerebral palsy, encephalitis, previous stroke, etc. So-called remote symptomatic seizure. Now, having said that point, come to the next point, how to start that drug treatment. There are certain principles. The principle number one is that start with only one drug because it can control as much as 60% of the instances of epilepsies. Now, polytherapy has got certain disadvantages because if you combine two drugs, the drugs may interact. The effective level of either drug may not be reached. We may not be able to determine the responsible agent in case the patient develops any side effect due to the drug. They are likely to be less compliant when you give more than one drug. And after all, obviously, the effectiveness of individual drug cannot be assessed. So what is the second principle is that start with a small dose of the first line drug. What is the first line drug? I will come later on. And wait for the steady state to be achieved. What is the steady state means? The time taken for the constant blood level to achieve after administration of each dosage. But the fact here is that unlike the treatment with antibiotic for infections, the antiepileptic drug level has to be constantly present in the blood for the antiepileptic effect to occur. So that's called the steady state. And if the steady state has to be achieved too rapidly, you have to give a loading dose, either by intravenous route or by a heavy dose to start with. Now, what is the time taken for the steady state to achieve? Depend upon the half-life. So these are the half-life of the various antiepileptic drugs. You can't remember these half-lives. We can't by heart this. Generally, take that is 2 to 4 days for all antiepileptic drugs, except 3 drugs. One is a phenytoin, second is lamotrigine, and third is onisamide. These drugs has got a long half-life, say up to 2 weeks. So it mandates that you have to wait for at least 2 weeks for the efficacy of the drug to be assessed. Or withdraw the drug or increase the drug dosage, you have to wait for at least 2 weeks. Then only you can assess the efficacy or the side effect of the drug, the efficacy of the drug. If the seizures are not controlled with the minimum dosage, you escalate the dose to the maximum tolerated dose till the drugs are under control, or the side effects were due to the drugs preclude further dosage increase. Now, in that situation, you have to add another additional drug. If the patient does not respond to the maximal tolerated drug, you have to either switch the drug or change to another drug or add another AED to the existing drug. So the question now comes, you want to switch the drug or add the drug if the first drug fails. The first drug is ineffective but not tolerated. That means no question, you can rapidly taper the first one and add another. So immediately switch to another drug. On the other hand, you find that first drug is partially effective. For example, the seizure frequencies come down with the first drug, but not totally controlled. Then it's prudent to add another drug. If the seizure is getting not controlled with adding second drug, you may try to taper off the first drug after a waiting period of 3 to 6 months, because you want to know your second drug has taken its effect or not. The seizures continue despite 2 monotherapies, then you have to go for a polytherapy, that combination of drugs. The seizures are resistant to polytherapy, other treatment options like surgery and wake stimulation. Now coming to the most important question, which AED in the present era. Now these are the number of drugs available in the market. You see from 1984, for the last 2 decades, the number of drugs has gone up tremendously high. So among this whole lot, which drug we have to choose? It's a big question. Now, if you ask me which is the best first drug, it's not a question. It's not a scenario of one-size-fits-all scenario. The choice of drug depends upon many factors. One, the disease characteristic, depend upon what type of epilepsy you're dealing with. It depends upon the drug characteristics. It depends upon the patient characteristics and socioeconomic and personal preferences. Let us see these various factors one by one. The most important is that disease characteristic, what type of epilepsy are you dealing with? That is epileptic syndrome, or the type of epilepsy, is it focal or generalized, and the frequency of the seizures. Now, the drug characteristics is important. The most important is efficacy of the drug. We want to know that drug is efficacious or not, and the side effect profile of the drug. Because children naturally require a drug with a low risk of drowsiness and cognitive dulling. Other factors like half-life of the drug, which decides the number of doses per day, ability to titrate rapidly, because we have got a frequent seizures, you have to give a drug which takes its effect quickly. We won't prefer a drug like lamotrigine with slow pickup drugs. Interaction with other AADs and other drugs are important, drug-related characteristics. Then the patient characteristics are age and sex. In the newborn, as you all know, phenobarbital has long been used as a first-line drug. And you have to change the drug depending upon the associated comorbidities like liver disease, renal functions, behavioral problem, obesities, and co-medications. Because risk of liver failure with valproic acid in patients with mitochondrial disease. In polygene mutation, if you inadvertently give this drug, you can go into irreversible coma because of the toxicity. Then a higher risk of Stevens-Johnson syndrome if you expose the patient to carbamazepine or roscarbazepine. In those Asian patients with HLA-B 1502 allele, if that also you have to, these are things that are to keep in mind, patient characteristics. And the patient previous medications the patient has received also determine which drug to be chosen. And in our country, socioeconomic and patient bills are very important. Many drugs are costly, especially the newer drugs. Some of them are not available. And of course, the use. See, we prefer a drug which I have been using for a long period of time. We are comfortable with it because we know what are the efficacy, what is the side effect, whatever the literature say. So we prefer some drugs. So these factors are all determined which drug has to be chosen. Now, there are certain situations where you don't want to start a treatment, even if the child has got more than 1 or 2 episodes. For example, benign focal epilepsies. Why do we don't treat such benign focal epilepsies? Because these epilepsies are mainly nocturnal seizures. They have no faults and no injuries, unlike an adult. They are not dead on drive. They are self-limiting epilepsies, whether you treat it or not. Excellent prognosis. And 30% have only one attack in their lifetime. And 60 to 70% only less than 5 to 10 attacks over 3 to 4 years. However, there are certain situations where you do need to treat even benign epilepsies. You provide the child has got frequent seizures to prevent status epilepticus. Some children get frightened by the seizure, and more so the parental anxiety is an important factor. Probably the most important situation is the atypical evolution of the benign epilepsy, especially the benign rolandic epilepsy. About that, I will be coming to talk to you later on. So summing up, having said all these factors, ultimately what decides is 3 things: the efficacy, tolerability, and the cost. Other factors, of course, influence the treatment choice, but these are the important factors. Now let us see, the most important factor is efficacy. How do you choose a drug depending upon to find out that drug is efficacious or not? It is determined by the type of epilepsy or seizure or epileptic syndrome. What are the steps to choose the drug? Try to find out the epileptic syndrome if possible. If it is not possible, try to find out the type of seizure, whether it's focal or generalized seizure. And if that is not possible, you have to give a broad spectrum anti-epileptic. This is the general principle. Now, what is an epileptic syndrome? It's electroclinical syndrome, syndromic diagnosis, irrespective of the etiology. It takes into account the clinical scenario, EEG characteristics, age of the onset, characteristic evolution and progression, and presence of absence of family history. Then why do you want to know about this epileptic syndrome? Why can't we just treat it just by looking at the type of seizure itself? because we know whether to investigate the patient further or not. And the patient was asking about doing MRI in every patient. In fact, at the present, there are all focal epilepsies, we need to do MRI. But there are certain situations, if you can identify the epileptic syndrome, for example, absent seizures, juvenile myoclonic epilepsy, benign rolandic epilepsy, we need not do an MRI at all. So it also tells you which drug is to be given. If you have absent seizure, you know the child requires ethosuximab or sodium valproate. That way you can tell you, can go straight away to the drug which is required. And of course, you can predict the prognosis. You can in benign rolandic epilepsy, you can tell the parent nothing to worry, your child is going to be perfectly all right after 2 years. So those things you can do if you can identify the epileptic syndromes. Now, what are the drug of choice in each syndrome? Neonatal seizures, phenobarbital is preferred. The West syndrome, ACTH and vigabatrin. Other options include valproate, topiramate, LTG, levetiracetam, and sonizumab. I think remember the drug of choice will be better rather than remembering all the other drugs. LGS, levonorgestrel, sodium valproate, and clobazam is another good drug option for levonorgestrel syndrome. And rufinamide is not available in India. Benign rolandic epilepsy, either carbamazepine and valproate. Absence epilepsy, no doubt, valproate and ethosuximab. Juvenile myoclonic epilepsy, valproate. Dravet syndrome, clobazam, clonazepam, and valproate. Landau-Kleffner syndrome, steroids, because it's an autoimmune etiology, thought to be the responsible factor. Other drugs are lamotrigine and valproate. Febrile seizures and early benign occipital epilepsies need not give a long-term treatment. You can give intermittent diazepam, intermittent therapy to control the seizure. Late onset childhood occipital seizure, you have to give carbamazepine. And continuous spike wave discharge during slow wave sleep is an epileptic encephalopathy, which required steroid, and other drugs which are effective are clobazam, valproate, and clonazepam. Myoclonic static epilepsy, clobazam, clonazepam, and valproate. Now, if you are not able to identify an epileptic syndrome, which is often, most of the time, that's the situation. Child, 5-year-old coming with one episode of seizure, we don't know what does not fit with the epileptic syndrome. In that situation, at least try to exclude JME and absence. Because absence, you can easily exclude by asking the child to hyperventilate in front of you and it can precipitate an attack. JME, you can ask for the history of early morning myoclonus or dropping things from his hand, because the patient will not, or the parents will not divulge the history unless you ask for it. Because this is important to recognize, exclude these two conditions, because the other common drugs which you prescribe are contraindicated here, will aggravate here. For example, carbamazepine phenytoin will aggravate juvenile myoclonic epilepsy. Carbamazepine phenytoin vigabatrin will aggravate absence seizures. If you are not able to identify the epileptic syndrome, then find out what type it belongs to. Is it a focal becoming generalized or a primary generalized epilepsy? Because the drug of choice depends upon the seizure type. Now, focal and generalized, this is not sometimes to distinguish focal generalized, sometimes not possible in young children, especially in young children, because more so in infants. Because the most important history to differentiate the two is the presence of aura. If aura is there, we know each child has got a focal epilepsy, becomes secondary generalized. So this part of the history to differentiate between the two cannot be obtained from children. Some children can have both focal and generalized seizures. Dravet syndrome, for example, usually presents with hemiconvulsions. In febrile spasms, the pattern can change from generalized to partial seizures. So sometimes this different distinction to differentiate partial becoming secondary is become impossible here. If you are not able to find out the seizure type with a broad spectrum anti-epileptic drug, then you may ask, why do you want to go for this havoc of differentiating between the two? Why don't we just start a broad spectrum anti for all children? But remember that this broad spectrum anti-epilepsy are broad spectrum, but not that efficacious for a particular type of particular seizure type. So try to find out the seizure type as far as possible. Now, which are the broad spectrum anti-epileptic drugs? Valproate, lamotrigine, topiramate, and levetiracetam and clobazam are the broad spectrum anti-epileptic drugs. Now, what are the choice for if you find out if you have got a focal epilepsy or a focal becoming generalized epilepsy? which anti-epileptic you choose. Almost all drugs are effective, except for ultrasoxamide. So these are the list of drugs which are approved for in UK. Which drug to choose among them is determined by the other factors like the cost, cost and availability and things like that. In the case of generalized seizures, the most preferred drugs are sodium valproate, lamotrigine, levetiracetam, topiramate, zonisamide, phenobarbital, and again, the choice depending upon other patient characteristics and drug characteristics. If you've got certain guidelines, these guidelines are not always fruitful for individual patient. Guidelines say that children with partial onset seizures, there is level A evidence of carbamazepine. Generalized seizures, guidelines say carbamazepine, phenobarbital, phenytoin, topiramate, and valproate. Absent seizures, I think there's no question about valproate, indocyanide, and sometimes lamotrigine. Penirolantic epilepsy, carbamazepine, valproate, and JME, there is no level of evidence, but the ideal drug is sodium valproate. Now, so-called recommendations are based on placebo-controlled RCT studies. For individual patients, this is not applicable all the time. Let us see what drugs you use generally. You use a newer drug or an older drug or a newer drug. Personally, I always prefer an older drug because I've been using it for long and comfortable with that. That does not mean that we need not use a newer drug. We have to use it at some time. Let us see what are the situations where I'd like to prefer a new drug. And is the newer drugs more efficacious than the older ones? So just go into that aspect. For the partial seizures, these drugs are older drugs. Carbamazepine, phenytoin, sodium valproate are all effective, but carbamazepine remains a drug of choice, except for children below 6 months. For all forms of primary generalized seizures, valproate is a drug of choice. Absent seizures, valproate is indocyanide. Now coming to the newer AEDs. What is the real advantage of these newer drugs? What are the situations where you can use these drugs? In fact, there are no major difference in efficacy between these drugs, with the old drugs and the new drugs. However, there are major differences in side effect profile, and the drug interaction also differs. It is drug of choice to be tailored to the patient depending upon whether the first drug is producing a side effect or not, rather than it is efficacious or not. Now, there are not many RCTs comparing old drugs and new drugs. These are the few, not all newer drugs. They show that there is no difference between the efficacy of the older and new drugs. Now, what are the newer drugs which are effective for partial epilepsies? Lamotrigine, carbamazepine, clobazam, gabapentin, and topiramate, and norepinephrine. But remember, the efficacy is same as that carbamazepine, all these new drugs. The new AED for generalized seizures, lamotrigine, topiramate, clobazam, zonisamide, levetiracetam. And carbamazepine, gabapentin are ineffective for generalized seizures. Now, in the present era, many drugs, now new drugs are available. It is a difficult decision to choose the best drug possible in individual case. So what we need is comparative studies between the drugs which are the old drugs and the new drugs, there is established drugs and new drugs. Unfortunately, well-conducted randomized controlled trials providing such information children are lacking for several AEDs. This is one study, the Sanad study, which compared established versus new drugs. The conclusion is that another good drug for partial epilepsy is lamotrigine. The study has shown that point. But the valproate remains, even comparing with newer drugs, valproate still holds the gold standard for the generalized epilepsy. Now, there are some results of network meta-analysis. That means which allows researchers to combine the direct evidence with indirect evidence across network of drugs from many trials. These trials, meta-analysis shown that for focal seizures, lamotrigine, levetiracetam, the new drug, were significantly better than carbamazepine, which is the good old drug, which is better than phenytoin and phenobarbital. For generalized seizures, valproate continued to remain superior to other drugs. There is another network meta-analysis conducted in pediatric patients. which again bounce back and telling you that carbamazepine and lamotrigine were superior to new onset epilepsies, even compared to levetiracetam. Levetiracetam peramide may have some advantage in refractory focal epilepsy. This is their conclusion. So even now, even with the new drugs, the preferred drug for focal epilepsy remains carbamazepine or carbazepine, followed by lamotrigine and so maybe levetiracetam. For generalized seizures, sodium valproate, followed by then other drugs comes in second line. Always remember these points. Inappropriate anti-epileptic drug choice can produce seizure worsening. For example, carbamazepine can worsen absence epilepsy, junior myoclonic epilepsy, progressive myoclonic epilepsy, and benign prolandic epilepsy in some cases. Phenytoin can again do the same thing, can worsen absence of junior myoclonic epilepsy. Phenobarbital can worsen absence epilepsy. Benzodiazepines can worsen the non-gesture syndrome. Both vigabatrin and gabapentin, which are not routinely used now, as vigabatrin only in tuberous sclerosis producing infantile spasms, they are produce absence epilepsy and epilepsy with myoclonus can worsen. Lamotrigine can worsen severe myoclonic epilepsy of infancy and the Dravet syndrome. And even though lamotrigine is a drug effective for juvenile myoclonic epilepsy, it can sometimes worsen that epilepsy. Having said that, one should also be aware of certain paradoxical effects, where the result is not totally what is unexpected. You know, carbamazepine is the drug of choice past epilepsies, but certain past epilepsies it can produce worsening. For example, certain frontal lobe epilepsies, benign prolandic epilepsy, Landau-Kleffner syndrome, benign occipital epilepsy, etc. They can induce negative myoclonus and atypical absences that correlate with bilaterally synchronous discharge in the EEG. IV benzodiazepine is the drug of choice for all status epilepticus, but it can precipitate tonic status in Lennox-Gastaut syndrome, even the child is already on oral benzodiazepine. Valproate is a drug of choice for absence seizures, but sometimes it can produce increasing the absence in childhood absence epilepsies. Lamotrigine can precipitate absence seizures in benign prolandic epilepsy and myoclonic status in Lennox-Gastaut syndrome. So, having said that, the drug of choice for these epilepsies and certain paradoxical effects that also to be kept in mind in case your drug of choice fails to achieve the intended goal. Then come to the other factors which modify your drug selection, the comorbid conditions. The child is obese, the preferred drug will be topiramate and zonisamide because valproate carbamazepine can produce weight gain. Migraine is associated with the patient, the preferred drug will be topiramate and valproate. Comorbid depression, avoid drug of choice is valproate, carbamazepine, and lamotrigine, which is good mood stabilizers, and avoid levetiracetam and perampanel. Behavioral problem, the ideal drug would be lamotrigine, valproate, carbamazepine, just like comorbid depression. Again, avoid levetiracetam, topiramate, and perampanel and phenobarbital. If the liver disease is the comorbid disease, the preferred drug is levetiracetam, gabapentin, or topiramate, and zonisamide. Avoid valproate. And also, you cannot combine topiramate with valproate because that combination can produce liver toxicity. In kidney disease, just to the opposite of liver disease, which are the drugs which prefer liver disease are contraindicated in kidney disease or late contraindicated kidney disease, like levetiracetam, topiramate, zonisamide are not preferred in kidney disease. The second most important aspect deciding on the drug selection is the tolerability. Because there are certain important aspects here which the family may not accept, the rare but life-threatening side effects. If you say that the best drug like carbamazepine or the second line lamotrigine can cause Stevens-Johnson syndrome, the parents may not accept that very easily. The best drug for the sodium valproate for generalized epilepsy can produce hepatic side effects. Behavioral discontrol with levetiracetam and phenobarbital. Cognitive dulling with topiramate. Now, if you generally take the tolerability of anti-epileptic drugs, among the older anti-epileptic drugs, valproate and carbamazepine are better tolerated than phenobarbital and phenytoin. I mean, the newer AEDs, gabapentin, levetiracetam, lamotrigine are better tolerated than oscarbazepine, topiramate, and vigabatrin because they have got higher treatment withdrawal. Now, there are certain issues with valproate in infants and children that also one should be aware of. You know about these things, the valproate hepatotoxicity. This is increased below the age of 2 years, increased with polytherapy, when there is increased, when there is associated psychomotor delay, and undiagnosed inherited metabolic. This again should be very careful. Carnitine deficiency, Alpers disease, and Golgi mutation and mitochondrial diseases. You should not give this drug because the sodium valproate interface with mitochondrial function can produce devastating sequelae if you combine these in valproate. So preferably avoid in infants with abnormal liver function test, multi-organ failure, polytherapy, and in those where the exact etiology is unclear. Now, there are uncertain side effects are peculiar to children, certain antiepileptic drugs. Phenobarbital can induce behavioral side effects, which you all know, 1/3 develop hyperexcitability, insomnia. Benzodiazepines can induce paradoxical hyperexcitation, unlike in adult. Clonazepam can produce bronchoria and dysphagia. Vigabatrin can produce hypotonia and somnolence. The retinal toxicity, which is seen in about 40% of the patients, children with vigabatrin, but is less common than in adult. Topiramate can produce metabolic acidosis in infants, and phenytoin can worsen progressive myoclonic epilepsies. Now, we can't remember the side effects of all antiepileptic drugs, but we need to know certain key side effects which mandate stopping the antiepileptic drug. For example, clobazam. If the behavioral changes irritability, so one of the good drugs is clobazam, but we have to stop that medication. Topiramate curiously can produce language disturbances, speech problems, and of course glaucoma. Levetiracetam can produce mood changes and behavioral changes. Lamotrigine, of course, rash, that's a Stevens-Johnson syndrome. Zonisamide can produce mental slowing, hyperhidrosis, and vigabatrin can produce visual field deficits. Finally, what drug will you choose in a particular case? So no antiepileptic drug is superior to carbamazepine in partial onset seizures. However, new antiepileptics like lamotrigine and levetiracetam are equally effective, but not supersede carbamazepine. So just by the fancy of the new drug, don't go for it because it's as effective or more effective than that. But one should be aware of the disadvantages like enzyme inducer. There's a question of auto-induction, frequent interaction with other drugs, and hormonal derangement can occur. Now, among the newer AEDs, only oscarbazepine and topiramate are FDA approved. And between the two, oscarbazepine is always preferred because topiramate has got cognitive side effects. What are the advantages of oscarbazepine? I now started using only oscarbazepine because it has got a weaker enzyme induction. There is no auto-induction, less frequent hormones, and absence of interaction with erythromycin. But only disadvantage is that it's got more tendency to produce hypernatremia compared to carbamazepine. Lamotrigine was found to be equally effective in comparative studies, fewer cognitive side effects compared to carbamazepine, and does not induce bone density changes. But the drawback is that it needs a very slow titration. You cannot quickly introduce a drug. You have to start with a low drug because if you give it too rapidly, it can produce Stevens-Johnson syndrome. It's more likely with the rapid institution of the drug. Levetiracetam is found to be almost equal to carbamazepine. Its good advantages, absence of interaction and enzyme induction. The only problem is a behavioral side effect. Clobazam is a very highly effective add-on treatment for many epileptic syndromes. Can be useful in partial and secondary generalized epilepsies, good for absence seizures and myoclonus. Raynaud syndrome and epilepsy, this ESES is the CSW, the continuous spike wave during slow wave sleep. Alcohol withdrawal seizures, benign partial epilepsies. It can be given as intermittent therapy in ketamine epilepsy also. If you want to have a rapid effect to pick up for an acute situation, you can give clobazam. If carbamazepine, I told you, is the first drug, if it is not tolerated, because the tolerance is the problem, change to carbamazepine or lamotrigine. If the carbamazepine fails to control, levetiracetam or topiramate are likely to be more powerful than gabapentin and lamotrigine. And valproate remains an option. For generalized seizures, the older drugs, valproate is the drug of choice. Other drugs are less efficacious. The newer drugs, topiramate is only approved by the FDA for first-line treatment. Lamotrigine, levetiracetam are FDA approved for adjuvant therapy. For general myoclonic epilepsy, valproate is always superior. If contraindicated, lamotrigine, which can, the side effect of lamotrigine is can worsen the myoclonus of JME. Other drugs which are useful for JME are topiramate and zonisamide and levetiracetam. Absent seizures, valproate ethosuximide. If one fails, you can choose the other one. If both, either of them fails, you can combine them. They can be effective or they can be effective. In the case of myoclonic seizures, valproate is a drug of choice. The other drug which are contributions is clonazepam. And the newer AEDs, levetiracetam, lamotrigine, topiramate, zonisamide can be useful for myoclonic seizures. Now, finally, the choice of drug, you are the judge. The choice differs between doctors, mainly based on their experience and the population they are dealing with, the rural population, urban population. The preferred drug for focal seizure, as far as I'm concerned, I prefer the drug for focal seizure, carbamazepine. The second add-on is clobazam. For IG, the generalized seizures, preferred drug is valproate. The second choice will be lamotrigine, levetiracetam. This is my choice, but that need not be your choice. It all depends upon your experience with your patients. Now, the next question is, what if the first AED fails? If you look at this graph, the chance of getting seizure control is nearly 50% in the first AED. With the second antiepileptic drug, is only 13%. With the third one, it is only 3%. So if you add more and more drug, chance of your seizure getting controlled is become less and less. Now, if you want to combine a drug, how to combine? That's another thing. Use AEDs with different mechanism of action. For example, you can combine a sodium channel blocker like carbamazepine with GABAergic agent like sodium valproate. And use combinations with favorable pharmacokinetic interactions. For example, valproate and lamotrigine. Because they have got lower doses of valproate is only required when you combine with valproate. And avoid combinations similar mechanism of action and or unhelpful pharmacokinetic interactions. But never combine carbamazepine with phenytoin because both are sodium channel blockers and they could added toxicity. So also carbamazepine, lamotrigine, they are both also sodium channel blockers. Now, what drug will you choose an add-on? There are many studies. I think I will not go into this treatment when the study is proper. Just remember that 3 drugs have been found to be as a good add-on if first drug fails. That is a topiramate, lacosamide, and pyraminamide. Now, are certain specific drug combinations more useful than others? Yes. In absent seizures, combination of either specimen is better than either drug alone if either drug fails. Combination of valproate clonazepam is additive in the case of myoclonic seizures. Carbamazepine may get better in partial seizures, and lamotrigine and valproate is a good combination for generally uncontrolled generalized seizures, general myoclonic epilepsy, and even in partial seizures. Now, these are the NICE guidelines. I do not know if I should go for that or not. According to this NICE guideline, the first line treatment focal seizures in children, young people, and adults is same. Offer carbamazepine or lamotrigine as a first line treatment. Offer levetiracetam, carbamazepine, sodium valproate. If carbamazepine or lamotrigine are unsuitable and not tolerated, the first AED tried is ineffective for alternative from these 5 AEDs. Adjunctive treatment, if you want to combine it, you can combine with carbamazepine, clobazam, gabapentin, lamotrigine, any of the other things can combine. For generalized seizures, of sodium valproate as a first-line treatment, or for lamotrigine, sodium valproate is unsuitable. Then this is the add-on drugs, can offer clobazam, lamotrigine, levetiracetam, sodium valproate, topiramate. For JME, sodium valproate is the first line. If Consider other drugs, it fails, lamotrigine, levetiracetam, metoclopramide. Now, if the combination therapy also fails, you can consider surgery. If that is not an option, you go back to the combination which will not control your seizure. It can get optimum control, but not producing much side effect. You have to draw a line between the two, where at what level you want to stop escalating your anti-epileptic drug if you find the side effects are overtaking the efficacy. Now, these are the newer drugs in the market. I shall skip that thing. Now, come to the dosage. Now, we need not always give a dosage which is given in the textbook. Many will not require the standard dose. You can start with a small dose and try to escalate if necessary. Generally, generalized seizures require less dose than the partial, because some of the juvenile macular epilepsies can be controlled with as little as 300 milligrams sodium valproate. And the dose interval is also determined with the half-life. For phenobarbital, phenytoin, and lamotrigine, you can need to give only OD dosage. On the other hand, those with a shorter half-life, like carbamazepine, valproate, you get BD dosage. If you give multiple AEDs, it can shorten the half-life. So what happens? You have to give, instead of giving 2 times, you may have to give 3 times in the case of carbamazepine. And generally, you require larger dose in children than the adults. Now, the last aspect in the principle of treating epilepsy is, when do you want to stop the anti-epileptic drug? If you stop the anti-epileptic drug after a period of 2 years of seizure freedom, the general chance of recurrence is 30%. And the most recurrence occur in the first year. The patient is seizure free for more than 2 years after stopping treatment. Subsequent recurrence risk is very low. Now, what is the duration? You want long time to taper or a short time? The probability of seizure recurrence after 6 weeks of tapering is equivalent to a risk after 9 months of tapering. So you need not taper very slowly. You can taper over a period of 2 to 3 months time. Now, what are the risk factors which predict seizure recurrence before you stop it? This you have to tell the patient. If an epileptic discharge is in the EEG at the time of withdrawal, onset of epilepsy in the adult complex partial seizure, juvenile myoclonic epilepsy, high chance of recurrence if you stop the medication. So also childhood absence seizure, epilepsy absence also has got a high chance of recurrence. And obviously childhood epileptic encephalopathies, seizures with underlying brain malformations, abnormal neurological examination. And secondly, to remote symptomatic etiology, old cerebral palsy or old head trauma or old encephalitis, subsequently presenting with seizure, they have high chance of recurrence when stopping. On the other hand, what are the epilepsy? Good prognosis, the chance of recurrence is very low. The age of onset is greater than 2 years and less than 11 years. It's a good chance of seizure freedom if you stop it. Idiopathic etiology, normal mentation, normal neurological examination. Child absence epilepsy and brain-Rolandic epilepsy has got excellent prognosis. And infrequent seizures. And seizure-free interval much greater than 2 years. So ultimately, the decision to stop AED has to be not a single one-way approach. You have to discuss the various pros and cons by discussing with the patient as well as the family. The following factors influence the ultimate decision. The risk of recurrence, which I already told you after stopping epilepsy. The risk of evolving intractable seizures after weaning. The potential risk of serious harm from recurrent seizures, including status epilepticus, pseudo and injuries and accidents. On the other hand, also you have to take into consideration other aspects. Some patients do not want to stop the not want to continue anti-epileptic treatment. The risk is high. They just want to get rid of the drug because the stigma associated with the treatment. And second, they may have got undesirable side effect which tell them that they don't want to continue. So all these factors have to be taken into consideration and take a decision, a combined decision to be taken. Now, if I got, can I go, how many minutes I have got more? 5, Antageshavan, can I have 5 more minutes? Yeah, then I will mention the two, 3 important, this thing I will, drug treatment, which is commonly common for the pediatricians. One is epileptic spasms. Because epileptic spasm occur in the setting of an epileptic encephalopathy, early diagnosis and aggressive treatment is important. It is recommended to start with as early as possible, ideally within 7 days. The drugs effective are steroids, either ACTH or prednisolone or vigabatrin. Vigabatrin has got superior efficacy in epileptic spasms caused by tuberous sclerosis complex. With all other etiologies, steroid is preferred. Now, what's the treatment regime? Many people follow their own regime, but this is what is advocated by the Pediatric Epilepsy Research Consortium. That is, for the 2 weeks, you get a heavy dose, 75 unit per meter square for 2 times a day. Then, within over a period of 3-4 times, rapid taper off. Oral prednisolone has got almost equal efficacy as ACTH. So the patient who cannot afford, who can really try, but think that the dosage should be high, not the small 1 milligram per kg body weight, which usually for other diseases. Irrespective of the age, between first to 14 days, you have to give 40 milligram per day for 2 weeks. Then you can taper off over a period of 3-4 times 10 milligram. Vigabatrin, the dosage is given here, which is not easily available here, and it's very costly and it's not available in the market. But it should be given, it's ideal drug in persons with influence spasm with underlying tuberous sclerosis. But remember that the retinal toxicity with the drug can cause, and it's very difficult to check the peripheral fluid in children. In resistant cases, you can give ketogenic diet, epilepsy surgery. Other drugs which have been tried but not approved are clonazepam, clobazam, topiramate, zonisamide, and valproate. We usually give pyridoxine combined with the other drugs because with the hope that it may do some benefit in infantile spasms. Camden-Law-Gestalt syndrome, as you know, it is a resistant treatment, almost always require polytherapy because, and many may experience adverse effect polytherapy affecting their quality of life. So the focus should be on the overall quality of the life and not seizure control per se. Many caregivers prefer rare or even regular breakthrough seizures over cognitive and sedating drug side effects. The first-line therapy is sodium valproate. If that fails, the adjunctive therapy is lamotrigine, which as you told should progress low titration. Second adjunct therapy is leflunomide, which is not available here. Subsequent adjunctive therapies are topiramate, clobazam, and felbamate. If you decide to give topiramate, beware of the cognitive and behavioral side effect. Clobazam is a very good add-on. May use intermittently during crisis also. It's particularly effective in reducing the drop attacks. Felbamate has got its own toxicity, like aplastic anemia and liver failure. So that the AD, there are other drugs which are approved tried without approval, like this, levetiracetam, etoposide, etc. And cannabidiol is another drug which has been recently approved by FDA for use in pediatric epilepsies, especially in Dravet syndrome and Lennon-Gestalt syndrome. And remember that can avoid sodium channel blockers like carbamazepine, which can worsen seizures in LGS. There are non-pharmacological therapy like ketogenic diet, and in resistant cases, you can give sedative surgery and vagal nerve stimulation. Now, I end my talk by this particular entity. It is important to recognize this one because the treatment is different and the outcome is rewarding. The electrical status epilepticus in slow wave sleep, also referred to as continuous spike in slow wave sleep, is unique epileptic encephalopathy in children, often between the age of 4 and 8 years, characterized by variable regression of language or cognitive function with other neurobehavioral problems secondary to near continuous epileptiform discharges in slow wave sleep. If that condition evolves the posterior language areas, seizures of the posterior language areas, they manifest with auditory agnosia and language regression, and that entity is called Landau-Kleffner syndrome. In fact, the ESES and the Landau-Kleffner syndrome are now considered as a continuum of and not as different entity. In one situation where the desires are mainly in the rolantic area or the insular area, where the language is situated and that produces chaos. If the seed desires are coming from the frontal area, they present behavioral problem. There the manifestation is electrical status with epileptic sleep. Here, the treatment options include steroid and high-dose nightly benzodiazepine. Here, the clobazam is really useful here with combined with steroid. The conventional AEDs may also reduce spike burden, but the more important thing is the cognitive improvement. The other drugs used are sodium valproate, ethosuximide, levetiracetam, clobazam, and salthiam. Salthiam is not available here. And remember this particular point. In these conditions, avoid carbamazepine, oscarbazepine, phenytoin, and phenobarbital because they are reported to worsen electrical status during storage sleep. And steroid has higher chance of success. Now, this entity is also one should be. We all come back to one of the commonest epilepsies, brain-related epilepsy. But sometimes the people, when you start carbamazepine, which is recommended as the first line, parents will come and tell you that the child is not doing well at school. He's not able to write properly. Has got some behavioral problem. In that situation, do an EEG during sleep. You may find that frequent discharges in the EEG, and that means that he's going for atypical neurolytic epilepsy. No, because their carbamazepine is gone. They stop the carbamazepine, change to clobazam or valproate and steroid. The child will do good in scholastic performance. Now, when you suspect your child is likely to have an atypical evolution, young age of onset of neurolytic epilepsy. So multiple, usually in neurolytic epilepsy, they present the focal twitching of the mouth, salivation, or focal sensory symptoms in the mouth. When you get multiple seizure types, like atypical absence or drop attacks, think that your child neurolytic epilepsy, even though the child is such to be neurolytic epilepsy, it's an atypical evolution. The seizures are frequent during night and daytime occurrence. Again, you think that the child is going to be atypical evolution. And awake EEG starts showing frequent discharges and profuse discharge during sleep EEG. Again, think of atypical evolution. Here, you have to stop the carbamazepine or phenytoin. You have to go for clobazam, valproate, and steroid. And if the absence is all associated, go for ethosuximide. I think I will extend my time. So thank you for patient listening. In conclusion, I may say that treatment of epilepsy, infantile epilepsy is largely individualized. Beware of the side effect profile as well as the drug and the cost and the availability and what you prefer in your situation, in your hospital or environment that decides the drug of choice. And we need not necessarily follow what is given as in the guidelines. Thank you for your patience.
Please. So thank you, sir, for the wonderful talk on practical aspects of epilepsy management. Some questions are there. Kumar, can you read some questions? Unmute. So before that, 2 questions from my side, sir.
Yeah.
So you mentioned about the genetic studies for drug reaction. So is it justified in future because carbamazepine, lamotrigine are a severe problem? I have lost one child due to side effects due to lamotrigine also. After that, I'm very afraid of using this one also. So what about the genetic studies? Too early to say then also.
Yeah, very good question. In fact, according to the FDA guideline, if you want to start this drug, either oscarbazepine or carbamazepine in a patient of age 963, you have to do this HLA typing. Otherwise, they can sue you for giving the drug. But the problem is it's not easily available. It's still available in Chennai and all. So what I have decided is that some of the people I tell them often this can develop, you have to stop at the very beginning. Or I have started using lacosamide. Lacosamide is another sodium channel blocker. It's a new drug, which I start because of the fear of the Stevens-Johnson syndrome. I've started using that one to be equally effective. Now, that has not come in the guideline or anything. This is my own experience. And I started asking people, they also said they would be found to be useful. So for focal seizures, now I started using lacosamide. But that's not the final word. I don't have much experience with the lacosamide. I started using only for the last 1 to 2 years after the drug has come. So that is where I prefer rather than oscarbazepine.
There is a related question also. What is your experience with the side effects with the carbamazepine and oxcarbazepine? There's one question also.
Yeah.
So, side effects with the carbamazepine and oxcarbazepine.
Yeah, the both can produce drug reactions in Stevens-Johnson syndrome, but Stevens-Johnson syndrome is much more common with carbamazepine than oscarbazepine. Second thing is that the oscarbazepine is little more better tolerated because interaction with other drugs is less. You can hike up the dosage too quickly because in the case of carbamazepine, we have to go a little more slower titration because rapid titration is possible with oscarbazepine. And auto-induction is not that oscarbazepine. Auto-induction means if you give the carbamazepine initially, it may, after some time, the drug level will come down and may produce a rebound seizure. You have to further increase the dosage. That auto-induction is not there in the case of oscarbazepine. The only drawback of oscarbazepine compared to carbamazepine is that the hyponatremia side effect is more common with OXC compared to carbamazepine. So even then, because we have fear of the Stevens-Johnson syndrome, I prefer oscarbazepine. Hyponatremia is not a big problem.
Next question, sir, was diagnostic pitfalls in pediatric epilepsy.
No, in fact, I have not touched upon the diagnostic aspects at all in this thing. No, as the chairperson initially told, there are very many syndromes in pediatric epilepsies. In the neonatal period, encephalopathies are there, benign epilepsies are there. The infancy also, benign epilepsy is there. And various dreaded epilepsies like Dravet syndrome is there. So the pitfalls is that you have to go meticulously with the clinical history, family history, and try to identify the epileptic syndrome and EEG. If you go wrong in the history taking, you can have a pitfall. But that's a long, each aspect is each epilepsy you have to take into pitfalls. That's not the same. I can't answer in a single word. Always remember, try to roll out the conditions which can mimic epilepsy in children. Like as told me in the first, second, third slide, like paroxysmal ataxia, dystonia, Sandifer syndrome, shuddering attacks, breath holding spells, all can mimic seizures, which need to be ruled out. So self-gratification syndrome, many things.
What about the role of levetiracetam and status?
Yeah, because that's another good question. No, all along we have been taught that the first line, a child person comes to with status epilepticus, give first line is lorazepam 1 milligram per kg body weight and give. Along with that, you start with phenytoin. That's our conventional way of treatment. But the phenytoin, the problem is that you have to wait for the full amount to be given. You have to wait for 20 to 30 minutes. Then only the trip will be over. There have been recent studies comparing phenytoin versus IV levetiracetam versus IV sodium valproate, even in children. They found that IV levetiracetam and sodium valproate has got more chance of getting controlled than IV phenytoin. So now that even though some old people prefer phenytoin, you can definitely give IV levetiracetam as the first line. I mean, in the sense that after lorazepam, after the benzodiazepine, you can straight away go to levetiracetam or sodium valproate. In fact, you can, after going to the advantage of levetiracetam is that you can push through. You can give it fast. You not wait for, let's say, a long time for phenytoin. And you know whether that IV drug is acting or not. If it's not acting, you can go to before going to the anesthetic agent like IV midazolam drip. You can try the other like valproate also during that time. So that way, IV levetiracetam is a good choice, followed by IV valproate. Then go for, if fail, go for midazolam drip.
Is there any recommendation for levetiracetam first line drug in children? First line, I'm asking, which is recommended? We are giving it. What is there's no recommendation?
No, so far, no guidelines recommend levetiracetam as the first line. No guidelines says that. Because even the NICE guideline I told you, it is not the first line. The studies have shown that the efficacy is equal to that of this thing, but still they are not coming forward as the first line. One important aspect is that you have to take into account the behavioral problem in the levetiracetam, which many of us are not aware of. Some children with unique levetiracetam, they become very highly irritable, angry, and things like that. So that becomes an issue in children with levetiracetam.
There's one question, sir.
Yeah.
If the clinical pattern of seizure does not agree with the EEG pattern, if the clinical pattern of seizure does not agree with the EEG pattern, would the drug selection be preferably based on EEG pattern or the clinical semiology?
Okay, that's a good question. So EEG here is, there you have to understand the pitfalls in the EEG interpretation. Always, if you've got a good history, tells you there's a focal epilepsy, it's a focal epilepsy, whatever the EEG says. Because, and the reason I'll tell you, even focal epilepsy, you may get an EEG of a bilaterally synchronous discharges, especially in frontal localization. Because the seizure discharge starting from one focus, it may be rapidly go through the contralateral cell to the corpus callosum, and both hemis will be activated synchronously, and you get EEG shows bilaterally spiked, bilaterally synchronous spiked discharge. Report will be bilateral generalized epilepsy. I had a bad experience here because initially I thought this child also had a background, so I thought it was very comfortable with generalized epilepsy. Child had worsening with sodium valproate. Then I admitted the child took in video EEG and found that clearly it's a two focuses coming either side. But most of the discharges are bilaterally synchronized. So that pitfall is there. So always take into consideration the clinical pattern, give weightage to the clinical pattern rather than the EEG. And another pattern for juvenile myoclonic epilepsy, you can have random spikes coming from either hemisphere, which one may interpret as a focal lesion. So again, EEG may be misleading. That's a generalized seizure may be mistaken as a focal seizure. So always give weightage to the clinical semiology. And thirdly, EEG may not pick up at all. During convulsion and all, the EEG may not pick up at all. Only muscle activity will be there.
So the next question was carbamazepine versus oxycarbamazepine. Adverse effects profile in your personal practice.
And I want to discuss again.
That already told. I prefer oxycarbamazepine compared to carbamazepine because the points I already discussed.
When a child is on monotherapy, comes with a single breakthrough seizure, is it necessary to give loading dose of the same drug, or can the dose of the drug just be hiked? If it is to be hiked, how much to do be? Means same drug, the aortic is loading dose.
No. Suppose child is got on monotherapy, has got a single as controlled, coming with another episode, we need not give a loading dose unless the child has got a recurrent seizures. Just one episode, need not just increase the dosage and then send the patient home because they already got anti-epileptic drug in their blood. You give loading dose in situations where you want to achieve the constant blood level rapidly. Okay, that's the situation. So, for example, if you've got a status coming, then you have to give IV. Recurrent seizures equivalent to status coming, you have to give a loading dose. For a single seizure occurring, you don't give a loading.
So what about advice? NC Nanda, please mute. NC Nanda. So what about doing EEG at the end of the epileptic treatment? How much it is helpful, or how will it guide us? EEG at the end of the treatment.
Yeah. Suppose the patient has been seizure free for 2 or 3 years, and you should do an EEG at the end of the treatment because the chance of recurrence is high if the EEG is abnormal. Now then you ask me, okay, you do EEG abnormal, did not stop it. 4 years, EEG abnormal, did not stop it. 10 years, EEG is abnormal, will you not stop it? That question you can ask. But their situation, I have stopped myself without recurrence. But always tell them that there's a chance of recurrence, which they have to accept it. So that is one of the risk factor or predictive factor for recurrence of seizures after stopping treatment.
You mentioned about at the end of 2 years, the chance for recurrence is 30% when you are stopping the drug.
Correct.
So we are testing up to 3 years. Of course, it will depend on so many factors. But some people are giving up to 3 years. Is it justified?
Yeah, 3. For focal epilepsies, it can be extended up to 4 years. I stop only after 4 years in the case of focal epilepsies. For other generalized epilepsies, I can stop after 2 to 3 years. For absence seizures, I just after 2 years. And benign epilepsy are 2 years. But focal epilepsy is 4 years. And especially if the child is on multiple drugs, we cannot control with single drug. We added another drug called under control. In that situation, we'll be very, very careful in tapering the drug. I'll try to prolong as much as possible. And 4 years is the minimum.
Parvati madam, Parvati madam is there. Professor Parvati madam. Unmute madam.
It is an excellent talk, sir.
Thank you, madam. Thank you.
It was an excellent talk. And sometimes the EEG may become maybe normal. In such case, if you may have to give anticonvulsants, no?
Absolutely. The decision to treat or not depends upon the clinical scenario and not by EEG. Because the pitfalls of EEG will tell you, in 40% of the instances, in clearly defined epilepsy, EEG may be normal. EEG may be normal. So for that, some people take prolonged EEG and repeated times may pick up abnormality. But it's always the clinical history which decides on the treatment. Second thing that, suppose a clinical history says you have a single blood attack, you are sure that it's nothing to do with it. Somebody asks for an EEG and EEG shows spike discharge. Don't treat that spike discharge. Your clinical judgment should overrule, because in 2 to 3% of the normal persons, the normal population can have really abnormal spikes in the EEG. So that means there could maybe a tendency, familial tendency for seizure discharge, but that does not make that the current event is seizure. So EEG always is an additive or complementary instrument to your history and never supersede your history. The history says you have syncope and non-epileptic discharge is non-epileptic, not epileptic. So EEG need not be abnormal. It all depends on you.
So, Dr. Gangadharan?
In fact, you need not take an EEG all the time. I don't take EEG many of the times. If it is very definite, you have seen the video and take a focal seizure, the aura is there. Where do you want EEG for? You know what the diagnosis is. EEG is not required. EEG is required when you got a pseudo seizure versus seizure attenuation, or you are not able to type the seizure, then EEG is required.
Is there any overuse of rate nowadays, and we are seeing some abnormal psychological behavior also? What's your comments on? Is there any overuse?
Overuse of medication?
Levetiracetam.
Yeah, absolutely. You're perfectly right, sir. Nowadays, everyone is started using levetiracetam.
Yeah.
They don't release 2, 3 things. One is the cost of the medication. Many of our people cannot afford. We just, I'll ask you one question to all of you. How many people will ask what the cost of the medication before you prescribe? When a representative comes in and tell me about a particular drug, the first question is, what is the cost of the medication?
Yeah.
Is it that I can't afford that medication? How can what other people can afford that medication?
I think levetiracetam is a very wide fluctuation. It's a wide range. The price is wide range. Some brands are very costly.
Very costly, and the efficacy I told you is as equal as other drugs, older drugs. So I never write levetiracetam as my first thing, except in situation older individual or got a liver problem. There I prefer. Older individual also prefer lamotrigine. If you want a slow titration, if you want a quick titration, go for levetiracetam. Or some other patients already got comorbid conditions and multiple drugs are patients taking, then I prefer levetiracetam. All of it.
I request Saroja Madam, Senior Pediatrician from Jubilee Mission Hospital, to comments for few comments. Saroja Madam also very senior, sir. Saroja madam.
Yeah, this was a wonderful session touching all the basics and how we should practice basics. I was also astonished to hear that there is no need for EEG if you take a proper history.
Yeah.
That's a good eye-opening thing. Thank you, sir. Yeah.
Thank you. Very much.
So it is a excellent, wonderful session, very practical management and dealing with almost all aspects of pediatric epilepsy. Now I request Dr. Edith Hanuma to wind up the session and to conclude.
Okay, thank you all for your patient listening.
Unmute.
Thank you, sir. Thank you, Dr. Madhusudanan, sir, for the session on the practical, on managing the practical aspects of pediatric epilepsy. We had some eye openers in certain areas, like about the EEG that you mentioned, and how to systematically start the drugs for each type of epilepsy. Thank you, sir. Anything more to add, sir? Clarifications.
Yeah. So thank you, sir. Thank you very much. I think it was a very excellent topic recently I heard on epilepsy. Very good, wonderful. Thank you, sir.
Thank you, sir. Thank you.
Thank you, sir.